Good afternoon. You know what time it is? It's 4 o'clock Mountain Time, which means only one thing. It is Fertility with Fink and Friends. I am Fink. You are Friends, 6 o'clock on the East Coast and 3 on the West Coast. And we are where we are every Tuesday afternoon at this time. And that is getting together and talking about all those things that are important to us. A special hello to Dr. Pena in Miami, who has graced us with his presence, one of the finest OBGYNs in South Florida there. Hi to Brandis, who has joined, Mrs. Amber Vince. Thank you for being here as always. Bubbles posed, hello to Zenaida, who I think you're number one. Equestrian, and nice to see you here as well. And over here on the CNY side, lots of our friends joining in. It looks like Danny is here, K-Way, Miss D, Jermel, Santa's San Diego, Shabnam, nice to see you as always. CK Schatz, Emily Wynn, hi Emily. All of our friends here, and we got a bunch of folks who've also joined right here in the middle. We've got two different feeds. As always, I've got my Instagram here, which is Randy Fink MD. We've got CNY's Instagram right here, and we've got LinkedIn, YouTube, and Facebook right here in the middle. So good to see everybody today. How's your week been? Our thoughts are going out for all the very strange weather phenomenon happening across the Midwest. Gosh, the tornadoes, the flooding in Houston. I've had a bunch of folks from Houston here this week, and fortunately, everybody has done okay. But lowlands, it's been dry. They said they need the rain, but they don't need that much rain. Yeah, kind of all scary stuff going on out there. So hopefully everybody is doing well. Crystal is here, and Crystal says, I'm looking at doing a third retrieval. My last one, I got 10 eggs and 5 day 3 embryos. How long should I prepare my body to hopefully produce better quality eggs? Okay, so that's a great question. What does it take? What does it take to make better quality eggs? And here's my feeling on that. The AMH is, of course, the measure of the anti-Mullerian hormone, is the measure of ovarian reserve. And that tells us really roughly what we have inside the ovaries, how many eggs kind of qualitatively are left or there. We can't change that, right? We can't change the number of eggs because you're born with all those eggs. The sperm that comes out today was manufactured in the male body about 3 months ago, but the eggs have been there since you yourself were in utero. So we can't change that. Transplanting eggs, can't do anything like that. But what we can potentially change is the quality of the eggs in the embryos, or in the ovaries, meaning to say the stability of the DNA. So as that DNA has been there for the entire time, well, certainly as we mature, it gets harder for us to have a baby. One of the reasons is because there are fewer eggs, but the other reason is because the DNA that's in those eggs becomes less stable, more likely to be abnormal, and thus more likely to create an abnormal embryo. If the embryo is not normal, it most likely will not stick. And if it does stick, it most likely will not grow. People do get concerned about, well, so, I don't want to have a chromosomally abnormal baby. Shouldn't I be doing the PGT testing? And I think that's a very realistic concern because people don't want to have abnormal children, obviously. But in the case of IVF, it would be very, very unusual to have a chromosomally abnormal live birth. I won't say that it doesn't happen because it certainly has. But in most cases, it simply, an abnormal embryo doesn't implant and therefore won't grow. You'll just never get a positive pregnancy test. The amount of time that is said to be able to affect the embryos is thought to be about 2 to 3 months. In the 2 to 3 months before that cohort of eggs is developed for retrieval, we probably have some ability to affect the egg quality. The first thing is there is a big list of supplements. It's a good chance for me to throw in a plug here for my ebook, The Vitamin Victory, which you can see at my link tree, linktr.ee, linktree/Randy Fink MD. If you forget that, it is the email address, or rather the website that's on the bio of my Instagram, which is Randy Fink MD. Click on that. It's a $7 ebook. It's got a coupon in there, so it gets you some discount on getting those supplements. But there are some different protocols. I will say also CNY and Molecular Fertility has some wonderful supplements for egg quality. The supplements there, there is an evidence-based protocol, and that is what I feel very strongly about, because the data is very clear that we can do something about improving that egg quality. So linktree/Randy Fink MD, and Linktree is linktr.ee, and that's where you can see that list and avail yourself of the discount in the ebook. So that's part one. What else can we do for egg quality? There is a medication that we often use in IVF for egg quality called metformin. Metformin, as you may know, is a medicine that's used for folks with diabetes. In women with polycystic ovaries, we will often use metformin to help to get folks to ovulate, to sensitize the ovaries, and to help with some issues with some of the hormone abnormalities that go along with that. And in IVF terms, we use it for egg quality, particularly with people who have both higher AMHs and in those who have lower AMHs. So the supplements, the metformin. Metformin is the medication version of a supplement called inositol, or myo-inositol. The inositol dose is 4 grams a day, 2 grams twice a day. But the medication is usually covered by most people's insurance. If your insurance covers it, it's going to be probably cheaper than the supplement is, because supplement's a supplement. And when it's manufactured through the FDA, then we know kind of what's in every pill. We know every 2 bottles is the same, and it may do a little better. A growth hormone is another thing, which is known as Omnitrope, is the brand we commonly use, although there are some other brands. Those are the first kind of things that are my go-tos for egg quality. And the one other thing is that usually a little bit of some priming can be very helpful. What is priming? Well, we're already priming you for 2 to 3 months, and that was the answer kind of to your question there, Crystal. 2 to 3 months is the sweet spot, is the window during which we can affect the egg quality. But 10 to 14 days of a little hormone, a little estrogen and progesterone before you start your stimulation can make a difference in terms of both sensitizing the brain to the hormones, in synchronizing the growth of the follicles so that they all kind of are able to grow together at the same pace. And in just juicing up the ovaries a little bit, helping with some blood flow, creating new blood flow going into the ovaries. So that's my recipe for egg quality, and I feel pretty strongly about it, especially in your case, Crystal, since you're going to be going into retrieval number 3. JM Dots asks, do you ever use low-dose naltrexone in your protocols? What does it do in regards to fertility support? So yes, low-dose naltrexone is a kind of a basic part of really all of our immune protocols. And what it does is that it stimulates your production of endorphins. We know what endorphins are. It's what causes the runner's high. What's kind of involved in post, well, we'll call it, what would be the politically correct terminology, post relations afterglow is endorphin. It's involved in, after childbirth, endorphin. The runner's high, and that's what low-dose naltrexone does. And what does that do? It has a significant boosting effect on the immune system. So in the anti-aging community, people will use low-dose naltrexone for long-term, and if you look it up and you read about it, you'll see people talking about, once you start on low-dose naltrexone, you're on it for a long time, you never get another cold. You'll never get the flu. There was a whole big thing about it, during COVID, that maybe it had some preventative effect on COVID. I'm not sure it was ever really studied, but so that's what low-dose naltrexone does. And yeah, it's a pretty straightforward intervention, and really does help both, I believe, with egg quality and certainly when it comes time for embryo transfer. Let's see, on the Facebook side, some special hellos to a few folks here. Looks like Jessica is here. Neri has asked a question a few times here, and so we'll jump to that one. Dr. Kiltz has recommended in his video for my modified natural transfer. Dr. Kiltz said modified natural, minimize the meds, letrozole, trigger shot, Prograf, push an extra 12 hours to transfer, take extra 12 hours of progesterone than we normally do. Could you please explain the thought behind pushing the 12 hours longer and what medication to take if I'm on immune protocol 2? I'm planning on taking 3 milligrams of Prograf for sure. Well, so first of all, yes, that Prograf, as we've talked about, I think really does probably make a difference in pregnancy outcomes. And that's based on a study that looked at recurrent implantation failure and recurrent pregnancy loss. We have always used Prograf in typically our level 3 immune protocol, but at a much lower dose. And the study now shows us that we should really be using 3 milligrams a day, and it has a very, very significant effect on increasing pregnancy rates, particularly for people who've had those issues before. So it's 1.5 milligrams twice a day. Prograf comes, it's generic, tacrolimus is what it's called, and it comes in both, it comes in a 0.5 and it comes in a 1 milligram. So if you're going to do the 1.5, it means that you have to get 2 prescription bottles, which means that you may have to pay 2 copays on it. In order to take a 1 and a 0.5 in the morning and a 1 and a 0.5 in the evening. The alternative is you can just get the 1 milligram, but you have to take it 3 times a day. And sometimes that does get hard to do. I have a very hard time myself remembering to take a medicine even once a day, no less twice a day. 3 times a day is probably a kind of a big stretch. So that's the story on the Prograf. I feel pretty strongly about it for everybody. If you're coming through CNY Colorado, there's a good possibility that if you're not already on it, then we are going to put you on it, or at least recommend that you take it. Now, modified natural means that you're using letrozole. The difference between a modified natural and a medicated cycle is simply that in a medicated cycle, we're giving you all the hormone, right? If we're giving you all the hormone, then your body doesn't have to make any of it. And in fact, what we're doing is that we're shutting down your body's ability to make that hormone so that we can control every single variable. We don't have to worry about a thing because every drop of hormone we're providing, telling your body, don't worry about it, we got this, and we're testing all those things. In a natural cycle or a modified natural, we are letting your body take the forefront as to where that hormone is coming from. You're making it yourself. We are still testing everything. So if your levels are not adequate, we will give you more. But the principal source of that hormone is your own innards, kind of your own ovaries, your own estrogen, your own progesterone. So letrozole just makes sure that you're building up a follicle. That follicle is lined with cells that are called granulosa cells, and granulosa cells make your estrogen. So what does that estrogen do? It does the same thing that it does every single month that you're not trying to get pregnant. It builds up your lining. That lining is trying to serve as a nice, spongy, warm, juicy place for an embryo to implant. When we see that that follicle has grown to a mature size, we can trigger the ovulation, which tells the ovary, release the egg. That, number one, starts the timing of when your transfer is going to be. But when the ovary releases the egg, you start making your own progesterone. That comes from a cyst, a type of cyst in the ovary that's called the corpus luteum. Your corpus luteum makes your progesterone. And what does progesterone do? Progestation, pro-pregnancy. It's the hormone that maintains the pregnancy. You make that your own. That corpus luteum is making your progesterone until about 10 weeks of pregnancy, when the placenta, 9 weeks really, the placenta takes over and starts making your progesterone at that point. So, is that a good thing? Yes, it is. There is some data, well, there's plenty of data that shows us that the modified natural or the natural cycle is at least as good as the medicated cycle, at least as good. And there is some data that says that it's in fact better, that there is a lower miscarriage rate, that there is a higher ongoing pregnancy rate. And we know for sure that there is a decrease in the risk for certain pregnancy complications, blood pressure type complications of pregnancy, as the clock wears on and you get more and more pregnant. So a modified natural is, instead of natural where you're just making the egg on your own, we're giving you some ovulation induction, which makes sure that you're going to make that egg in a timely fashion, and also has a pro kind of growth effect on the uterine lining. Okay, so that's the modified natural. As far as the timing of implantation or of transfer, I'm not sure what Dr. Kiltz's rationale for that is. I know that Dr. Abay has promoted that, and I don't know enough about it to know exactly what the details are on it. But I will tell you that in a natural or a modified natural cycle, the body typically compensates for the implantation window, that it doesn't need to be as precise as it is with a medicated cycle. And so if there are difficulties people have in terms of timing with the medicated cycle, using a natural cycle really just overcomes that difficulty. So hopefully that was helpful there. Neri, Jessica asked, I'm day 6 days past a 5-day frozen embryo transfer, and I started getting sick the day after transfer with a cough and congestion. Could that have impacted implantation? I feel discouraged that this transfer fails. Oh, I understand, Jessica, but you know what? People get sick all the time and still get pregnant. Would it have been my choice for you to get sick? It's bad timing to get sick. It's always going to make you wonder, make you worry that, gosh, what's my immune system doing if I got an upper respiratory infection? Is that going to somehow affect the lining of the uterus and how the embryo implants? There's no evidence that it does. So I think, we did see that COVID could have an effect on implantation and on egg quality, as well as on just, quantity of eggs being produced. But the fact that you got a little upper respiratory infection, cough, and congestion, I would not think that that's going to have a significant impact. Do I wish it didn't happen? Yeah, I wish it didn't happen, because now you're just going to wonder and worry. You know what? There's too many things to worry about in life, Jessica. So I think, let yourself get over the cold, and I think you'll be okay. But God willing, you're only 6 days after that frozen embryo transfer. So we still got a few more days before a pregnancy test would even start to show positive. So don't give up hope yet, my friend. Okay? I mean that seriously. Hi to Tara Lee, right in front of my face. Tara Lee 214. Thanks for being here. Emily Wynn is asking, I ordered my IVF meds yesterday and I'm starting at the Sarasota office on the 17th this month with my first IVF cycle. Well, you know what? And I have to tell you, I have not been to the Sarasota office, but I've seen pictures. It's a beautiful place, and all the providers and the staff there are really, really wonderful. Emily, everything is going to go great for you there. You're going to be in really, really good hands, and we are happy for you with our fingers crossed. Let's see who else. Hi to Shani W08 from South Florida. Yay! My second favorite place, because now I live in Colorado. If you didn't know, I am formerly from Miami, Florida, and have moved here to Colorado Springs and am now the clinical director of IVF services at CNY Fertility, Colorado. What time is it? 22 minutes after the hour. We'll be here for another 40 minutes. Bring your questions on, folks. Come on, let's talk. Amy says, Amy G. Jess, can you talk a little about the decision to do a back-to-back egg retrieval versus taking a month-long break between? Absolutely. A back-to-back cycle means that you are doing your stim, you're having your egg retrieval. Usually about 10 days later, you're going to get a period. And then after that period starts, that you're going right into another stimulation. That's called a stacked cycle or a back-to-back cycle. The evidence is very clear to us that when you do that, you typically get persistently escalating results each cycle that you do it. So you might do that 2, 3, 4, 5 times sometimes. When you stack them and do them in a row, really the medication that you used in the first cycle is going to continue to help you recruit eggs in the next cycle. And sort of a simple way to think about that is that, well, your body learned what it's supposed to do. And so once it knows what it's supposed to do, it just does it better each and every time. And yeah, that's a good thing. Sometimes we see that you get increased numbers of eggs, but the thing that is generally consistent, and every person is different, the thing that's generally consistent is that the egg quality improves with each successive cycle. So that's a stacked cycle or a back-to-back, as opposed to taking a break. It might make sense that you think, I had to go through that whole egg making process. Maybe I need to give my body a break so that I can, chill out a little bit, and maybe we'll do better if we give it a break. Well, the evidence shows otherwise. The medicine probably has a 2 to 3 month lasting effect in your body. So if you do need to take a break, you don't have to beat yourself up over it. You'll still get some benefit for the 2 to 3 months after that retrieval. But if you can go into a back-to-back cycle, then that's generally a good thing. There's another thing that we do sometimes that's called a duo stim. A duo stim. Duo stim is where you do your egg retrieval, and then about 4 to 5 days later, you go ahead and you start your next stimulation. That we commonly do, let's say, with folks who have a hard stop on when they have to get their eggs, like folks who, commonly in cancer patients. You've been diagnosed, you know that you're going to have to be starting chemo or radiation or have to do a surgery. And so the clock is ticking on us about getting those eggs. And so we want to sort of compact as much stimulating and egg retrieving as we can into a confined period of time. That's the most common use of a duo stim. Sometimes in a very low ovarian reserve situation, we might do a duo stim. But in somebody with a normal ovarian reserve, when we do duo stim, we typically do end up getting fewer follicles. Just a difference of a few days from starting that back-to-back cycle, kind of when you get your period. Typically, we do a little better. But do you have to wait? No, absolutely not. There is said to be, we think of a period Your period, your cycle average is what, 28 days, right? So if it's a 28-day cycle, then you're ovulating on about day 14. That there's one wave of follicular recruitment during your cycle. But what we actually know is that there are probably two waves of follicular recruitment, and that's what the duostem is kind of predicated on. But to answer your question there, Amy, back to back is generally a good thing. You do your stem, you get your retrieval. 10 days or so later, you get a period and you start on your next stem. We expect to have better results each successive time that you do that stacked cycle. Thank you for that question. Very much appreciated. Ludi S19 says, when do you stop taking the metformin and the low-dose naltrexone? Well, so many people will say stay on the metformin because metformin also decreases the risk of miscarriage and it decreases the risk of gestational diabetes. In your pregnancy. And so some would advocate, depending on your risk factors, you might actually stay on metformin for even much of the pregnancy. Low-dose naltrexone is also similar. You can stay on it long term. It is not said to have any adverse effect on the pregnancy and may just help you from an immune standpoint. But certainly, as you approach term, you want to be off it. Most of the time, we have people stop at around 12 weeks or so, although you can stay on it for longer than that. Let's see. Hi to Coco Fitness. Equestrian says, coming to see you on Thursday for first retrieval and hysteroscopy and polypectomy. Do we use max sedation? How long does the hysteroscopy usually take? Yes. So the sedation for your egg retrieval is really the same as we use for hysteroscopy here. You get a little medication through the vein, which puts you off to sleep. You get a little extra oxygen to breathe. And the hysteroscopy in my hands typically takes 2 minutes or less. It's very, very quick. Even removing a polyp, we can do that very quickly. The whole process, of your retrieval and your polypectomy, probably 15 to 20 minutes. So pretty straightforward stuff, and you'll wake up really just feeling great. A special hi to Alexis Laurenti at the Miami Center of Excellence, which is a wonderful place for women's health in South Florida. She is an extraordinary nurse practitioner. Coco Fitness is here. Can I come for treatment with a 5-centimeter dermoid, or do I need to remove it first for fertility drugs? Well, so it's a double-edged sword there, right? A dermoid cyst is the most common benign, what we call neoplasm or growth in the ovary. And a dermoid actually begins when you are in utero, and it will continue to grow over time in your ovary. When things get to be about 5 centimeters, we start to worry that it can cause the ovary to twist on itself, which is called an ovarian torsion. A torsion is a surgical emergency. And you think about what's happening there is that it's almost like a Christmas tree ornament, that's too big for the branch. If you put this big whopping anvil of a Christmas tree ornament on the branch of your Christmas tree, what's going to happen to the branch? It's going to go, it's going to snap, it's going to pull down. In the case of the ovary, that can happen with the whole fallopian tube ovary apparatus there. And when it twists on itself, it can result in cutting off the blood supply to that ovary. And that typically is the sort of thing that causes the worst pain of your life. It is not something that you have to wonder about. I wonder if I'm having an ovarian torsion. You know it. You are like, oh my God, something is not right. And you end up in an emergency room because, you can't. It's very easy to diagnose an ovarian torsion by ultrasound because when you look at the blood flow going to the ovary, there is none. So, I get concerned about that. And also when something's 5 centimeters, then we start to worry that maybe it's going to be taking up some valuable real estate in that ovary that the other follicles are going to want to use to grow. However, if you have surgery on that ovary to remove the dermoid, What happens is that you are disturbing the other follicles that are there, and you are going to have a lower ovarian reserve as a result. So, Coco, I would say it's probably fine to proceed with that dermoid there, even though it does also increase the risk of the ovarian torsion thing. Because what happens when we give you all this stimulation, that ovary is going to get bigger anyway. So it's something that we would really probably want to follow closely. But you do run a risk by having surgery on it before you do an egg retrieval. Hopefully that makes sense. Bubbles post says, what treatment do you use for someone with adenomyosis before a transfer? So adenomyosis is when the lining, that glandular lining that is inside the uterus. So let's talk about the uterus, our friend the uterus here. Most of the uterus is made of muscle, right? And the job of that muscle is to squeeze a baby out when that time comes. Until then, it's usually just kind of hanging out. Inside the muscle is a glandular lining, and that's the lining. They get thicker and thicker and thicker during the month to be the world's best baby blanket so that your embryo can land in there and get all wrapped up and cozy and grow. Well, there are some things that can go wrong inside the uterus. One thing is a polyp. A polyp is a finger-like growth of tissue that sticks up like a tree trunk or hangs down like an icicle. It's a fleshy growth of that uterine lining of the endometrium that's very easy to remove by putting a camera in. And usually we have a little instrument that goes like a Pac-Man, takes care of it, makes it gone. A fibroid is a ball of muscle. So there are different types of balls of muscle. Fibroids in the uterus affect about 70% of women. 7 out of 10 women will have some evidence of uterine fibroids. So if you think about this little organ, this little uterus on the inside that's mostly made of muscle, right? You know, from your bicep here, you can feel it, that muscle comes together in sheets. So feel your bicep, reach there and feel it now, and you can feel, this little cord of muscle that you can put your fingers around. Well, as muscle comes together in these little sheets, sometimes one of those little cells can get knocked off kilter. And instead of forming a nice little sheet, it forms, a little ball. And that's what a fibroid is. It's literally a ball of muscle. These little balls of muscle can be on the outside part of the uterus. They can be within the wall of the uterus, or they can sometimes be inside the cavity. When they are in the cavity of the uterus, that's when we say we don't want them there, because they too, a term I use is they're taking up real estate. They're affecting the endometrium, or that lining where the baby wants to grow and implant. So in that situation, we want that fibroid to be gone. Now, adenomyosis, Bubbles, is when that glandular lining, instead of just sitting there in a nice little spot inside, starts to dive down into the muscle. It's like dropping a well into your yard, but it's glands growing into the muscle, and that can cause some dysfunction in the blood supply to the uterus and in the way both the muscle and the glands will function. Now, adenomyosis used to be something that we could really only diagnose by having the uterus out, by seeing it under the microscope. Now, there's some pretty clear signs of what that looks like by ultrasound. You can definitively diagnose it by MRI, but most of the time we can look with an ultrasound and really see exactly what the situation is there. Now, adenomyosis may be considered a normal variant in women as we mature. It just kind of happens as those glands are hanging out in that muscle for your entire life, that they start to drop down and sort of become one with that muscle. But sometimes it can cause a problem. So classically, adenomyosis would cause a problem with pelvic pain and with heavy menstrual bleeding. As it pertains to fertility, I think the answers to that are less clear. But if we believe that adenomyosis is causing you a problem, then what we would do is treat it the same way that we treat endometriosis, which is with some hormonal suppression, typically for about 60 days. We can use Lupron to shut off the hormones. We can use Orilissa, which is an oral medication, or we can use Myfembree to shut down the hormones. And that usually has a suppressive effect against the adenomyosis, just like it does against endometriosis. So really good question there. Appreciate that question. Kaylee is here and says, if it does stick and is abnormal and quits growing, when do we know it quit growing? Okay, so I think we're talking about going back to my earlier conversation, talking about abnormal embryos in IVF typically don't implant. So you just typically don't get a positive pregnancy test. If you do, most commonly that embryo will stop growing, which ultimately results in a miscarriage. There are some different terminologies we use for miscarriage, and Kaylee, that means one of those things we call it a missed abortion or a missed miscarriage. A missed miscarriage is where the pregnancy just stopped growing. It doesn't slough off on its own. That we look and find, oh gosh, the pregnancy has stopped, and that's usually sometime in the first trimester, typically 6 to 7 weeks in most cases where there is a genetic issue involved. A spontaneous abortion or a spontaneous miscarriage is what we think of as a commonly known as a miscarriage. You start bleeding and the tissue gets passed. So that's usually kind of the way we see those things go down. And then you also ask, how long is one on Prograf until they're taken off of it? Well, if the issue has been implantation failure or recurrent pregnancy loss in the first trimester, usually we would stop you at about 12 weeks of pregnancy. Now, that study also looked at people with less than favorable pregnancy outcomes moving on. So some people have issues at 15 or 17 or 19 weeks. You can really stay on the medication as long as you need to. If you developed severe preeclampsia at 22 weeks of pregnancy, we would probably keep you on Prograf until, further on down the line than that, because it's said to help to prevent lots of different types of pregnancy dysfunctions. There is not enough evidence to say that everybody should be on it, because certainly everybody doesn't need it in general. But in the fertility community here, I think it's probably a reasonable thing to say through 12 weeks, unless there's some reason to stay on it longer. D is here, and D. Scott asks, do antibiotics hurt male fertility or semen? Not typically. We don't think of, so we know that there are some antibiotics that can affect your birth control hormone levels, but I have not seen evidence that most typical antibiotics should have any adverse effect on sperm or semen. Hi to Rebecca here as well. What's your recommendation on digging deeper on testing for endometriosis? Lots of symptoms pointing to endo, including several losses. We had one natural pregnancy that ended in a chemical pregnancy, and then our first FET was successful, and we have an 18-month-old baby. Second FET failed, and a natural pregnancy that ended in a chemical, preparing for another retrieval cycle. So, 2 ways to test for endometriosis, Rebecca. One is with the laparoscopy. And the laparoscopy is, of course, a surgery that's done with a camera going through your belly button to look on the inside, see what we see. It's done under general anesthesia. The other way to test for endometriosis is through a non-invasive test that's called Receptiva. My personal feeling is that, I do enjoy doing laparoscopies on people, but if you can avoid surgery, avoid surgery. It's a straightforward surgery. It's a simple surgery. If you have chronic pelvic pain, then it may make more sense to think about doing surgery, because if there's endometriosis, that's something that we can, treat at the time of surgery, and that may actually really do something to help with your, with your pain. But to do laparoscopy for fertility reasons alone is not something that I typically recommend. The Receptiva DX test, and their website is receptivadx.com, is a simple endometrial biopsy done at a particular time during your cycle that will tell us if you are expressing a particular marker called BCL6 that is associated with endometriosis. And if you are, the evidence here shows us 60 days of medication will turn off the BCL6 and dramatically increases your chance for pregnancy. Is it a perfect test? No, but it's a really good test. So, I believe strongly in it. And people say, well, then what, what's the problem? Why wouldn't I want to do a laparoscopy? It's very straightforward. And it is very straightforward. But surgery is always surgery. Even doing something simple like having a mole removed from your skin can result in a skin infection that leaves a big scar. There are always potential, there are risks associated with every single medical procedure there is. So if you can avoid that risk, I say avoid the risk. Receptiva is not covered by insurance. And that's a common criticism. I believe it's like $680 or $690 for the test itself. And there's only one lab that does it. And you'd say, oh, well, gosh, that's a lot of money. And it is. And it's true that your laparoscopy would likely be covered by your insurance. However, with copays, co-insurances, deductibles, anesthesia is going to charge you a fee, the surgeon's going to charge you a fee, the facility is going to charge you a fee, the pathologists are going to charge you a fee. It may very well end up costing you $1,500 or more, from doing a surgery. That again, if it's for fertility reasons alone, if we have a non-invasive answer, that's my personal opinion. Now, others think otherwise. You'll talk to Dr. Kiltz. Dr. Kiltz loves laparoscopy, believes that, and trained at a time that laparoscopy was a critical part of every person's evaluation. And so he can give you some very cogent arguments why laparoscopy is the best choice. But, you're always going to hear differing opinions on these things. And the important thing to know is that you have options. So, Rebecca, in your situation, I would think about, yeah, absolutely. You can do it non-invasively. It's worth testing. Let's see. Alex is here. Will priming help AFC? So an AFC is an antral follicle count. And an antral follicle count is if we take a look by ultrasound at your ovaries during the beginning of your cycle. Anything that's considered above about 5 little follicles that are hanging out there waiting to do something is considered normal. If there's less than 5, then we start thinking, maybe that is a decreased amount. Priming the ovaries may or may not have a direct effect on what that antral follicle count looks like. And it also depends really, Alex, on what you're priming with, because if you're on birth control for a few months, it's going to really quiet down the ovaries, and we may see fewer follicles, when we go to look there. So I would say, yeah, it's definitely possible. Priming does help the ovaries in general, but is an antral follicle count a good measure of how it helps? I'm not sure that that's necessarily the best measure. Hopefully that helps you there. Hi to Lori. Any updates on when the Virginia office will become full service? I don't know the answer to that question. So if you weren't aware, we have an office now in Norfolk, Virginia. And it is now a monitoring center. I believe they're doing andrology and things like intrauterine inseminations, IUIs. But when will it become a full service operation doing IVF? I don't know the answer to that question yet. Looks like Kelsha is here, if I'm saying your name correctly. I am 46 and my husband's 37. We'll be using a donor because I had an IUD taken out in February and no periods yet. Had a saline sonogram, no polyps or fibroids. I have children already from a previous marriage. No fertility problems, but my tubes are tied. How successful would donor IVF be for us? Are the odds better if you've had previous pregnancy? And what would be the best thing to do? Already had a consultation and selected the donor. So the issue there, Kelsha, and I forget. I think I'm saying your name correctly. It's kind of just at the wrong spot for my bifocals to see if that's an I or an L, but I think I got it right there. The biggest issue for you, my friend, is being 46. And so the odds of a pregnancy with your own egg would be very, very low. Why is that? Well, two reasons. One, because we talked about your AMH is going to be lower based on age alone. And secondly, the quality of the eggs is going to be such that most of the eggs that you are going to make at 46 are going to be chromosomally abnormal. Do you have a chromosomally normal egg in your ovary? I would say probably so. But how much stimulation is it going to take? How many cycles is it going to take in order to be able to get that egg? When statistically, your odds of a live birth using your own egg at 46 through IVF would be far, 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 far less than 1%. Whereas if you're using a donor egg, creating an embryo with your husband's sperm and placing that embryo back inside of you, your uterus does not age at the same rate that the ovaries do. So the ovaries age much more quickly, whereas a uterus, we can take someone who is thoroughly menopausal, 65 years old probably, and give them enough hormones to wake up the uterus and make it amenable to a pregnancy. So your odds of pregnancy using a donor egg are extremely high. So if you were to test those embryos you make, it would be if you have a chromosomally normal embryo, a 65% probability with the first embryo. Most of the egg donors that we use are young, healthy women. And if you grow that embryo out to the blastocyst stage, so typically a day 5 embryo, and you don't do the PGT testing, that would be a 40% probability of pregnancy with that untested blast. So your odds of pregnancy are extremely good using a donor egg. And that's why, when I have a consultation with someone and we talk about age-related diminished ovarian reserve and lower egg quality, I say, well, we've got a big, major uphill climb if we want to use your eggs. Some people want to try it, and I say, well, we certainly can. It's worth a try. I don't recommend that you do it ad nauseum, that you go on and on and on with it, because it can, become very costly with still an extremely low probability pregnancy if you don't respond correctly. But if you want to use a donor egg, I say we can probably have you pregnant here within, a few months. So the odds are very, very good, Kelsha, that you will become pregnant with your embryo that comes from the donor egg. So, gosh, exciting times, and fingers crossed for both you and your husband. Hi to Ashlyn. I have been watching you since December of 2023. Oh, awesome. Thank you. I've learned so much and ready for my first stem cycle at the end of May at the Norfolk location. Well, that is wonderful news. You'll be monitoring in Norfolk. Not sure where you're going to go for your retrieval, but thank you for watching Fertility with Fink and Friends. As always, I am Fink, your friends, right? We got about 10 minutes left here. Let's see what we can do for some questions. Bella Chanel says an AMH of 1.97. Is that good for IVF? Yes, it is. That is a very good number, my friend. Britt Morocco says, looks like can my day late eggs that were ICSI'd still, are we still able to be used? Can my day late eggs that were eggs? So I guess what you mean by that is, so it looked like, so you got some eggs, you did a retrieval. They looked at them day one. It did not look like they fertilized. So if we're not sure that they're fertilized, then we hold on to them and we look at them again, typically at day 3. So we tried to ICSI them, weren't sure that it worked, didn't look like they fertilized, held on to them, and in fact, they did. So yes, absolutely. So they'll look at them again. Now, sometimes the ones that look like they didn't fertilize, they didn't fertilize. And if that's the case, then a non-fertilized egg won't do you any good. But much of the time we'll find that, oh yeah, some of them actually did fertilize. When we're looking at them initially, day one after ICSI, you just can't tell that they had fertilized. And if you hold on to them and watch them again, you may see that they did. So yes is the answer there, hopefully, if I understood your question correctly. Little Oak 87 says, I just had my egg retrieval with you last Wednesday. Why do you discard unfertilized eggs? Because if the eggs did not fertilize, then they won't do any, they won't really do anything anymore. They will start to die off. So trying to save them just as a frozen egg really won't work. So if they didn't fertilize, it probably means something about the egg as well. There's probably a reason it didn't fertilize. It may not be a normal egg, so saving that egg wouldn't make a whole lot of sense. Hi to Sydney. I'm glad you are here, my friend. Let's see what else we got over here on the CNY side. Starting my first IVF cycle on the 17th. So excited. Silly 32 says, is abnormal embryo grow by 11 week? Well, not sure what the question is there. Rosa asks, I have a very low AMH, less than 0.3. If I take Orilissa for endometriosis, can I recover from it to do a modified natural transfer? Or will I go to menopause with Orilissa and my low AMH? No. Suppression of endometriosis will temporarily turn down your hormone levels. Orilissa turns down part of the hormone levels, not all of them. But neither of these medicines will cause none of these medicines will cause a permanent miscarriage. So the lower AMH suggests, well, okay, you don't have a very high egg reserve, which doesn't mean that you can't get pregnant on your own. It only means that, well, it tells us how you may respond to medications. So we can't really use the AMH level to predict when menopause will occur. But let's say that we have a younger person. Let's say that you're 32 years old and you go to an event where there's a booth and they say, check your AMH. We do that sometimes. Brandis and I have gone to public events and we do, little consultations with people who have questions about fertility, and we can check your AMH for very, very low cost, just so you know what your egg reserve is. Well, sometimes, what did I say? You're 30, 32 years old, you do your AMH and you find that it's very low. Well, that doesn't mean necessarily that you're going to have a premature menopause. It only means that the clock is ticking on the ovaries, which means we want you to think about doing something, either going ahead and getting pregnant now, or maybe think about freezing eggs just to protect your options for the future, because typically that AMH is not going to go any place but down over time, which means ovarian reserve is going to diminish. So we want to get some eggs now if we can, just to kind of as an a fertility insurance policy, because it tells us that fertility is what is going to be ending potentially sooner rather than later. Not so much that your premenopausal status is going to end sooner rather than later. Hopefully that one makes sense for you. And Maria King says, does delaying a cycle with estrogen and progesterone for a week before stems affect the success of retrieval? Well, it can, but in a good way. Probably not what you're thinking, that, oh, maybe that's a bad thing. Using that estrogen and progesterone can have the effect of sensitizing your pituitary gland in the brain to the hormones that are used for stimulating the ovaries, and can have an effect on synchronizing the growth of the eggs in the ovaries. So it actually may have a positive effect on you. So nope, not a bad thing at all. Shade says, my meds are sent in and also have something to look forward to as well, talking to Emily. Thank you guys for being friends to each other. We have a wonderful community here, and Really, it's a great thing. Does luteal phase stimulation help getting more eggs in women with a lower ovarian reserve? Sometimes, and that luteal phase stimulation is what we talked about called the duo stim. You do one retrieval and then you immediately go into another in the luteal phase. I typically do not start most stims in the luteal phase just because it's a little easier to start it at the beginning, but there's nothing wrong with doing that for sure. Monica Ashley says, I went for my FET monitoring yesterday and there was fluid in my cervix. Was placed on Mucinex. Will that help? I'm scared my transfer will be canceled. Getting another ultrasound on Thursday. Yes. So a lot of times we will see some fluid on the inside. Mucinex usually just kind of dries that right up. If I am going to do a transfer and I see that the lining is full of fluid, then yeah, I will say, you know what? That tells me that your endometrium has kind of been rubbed raw, and maybe there's something going on there that's not going to be hospitable to an embryo. But if there's a little bit of fluid there, sometimes we just put that transfer catheter in and we can just suck it right out, and then it's gone. As long as it's gone, I think you're fine to proceed. But Mucinex usually does kind of really help to dry that right up. Lily Rio says, what do you recommend I take to improve egg quality? I'm 43. There are 10 supplements that go along with egg quality. Please see my Linktree, linktr.ee/Linktree/ Randy Fink MD. And if you forget that, go to my Instagram. And Lily, you're on my Instagram. So it's the website that's in the bio. And there is a whole supplement protocol for male fertility, for embryo transfer, for regular ovarian reserve, folks just trying it at home, and for lower ovarian reserve, which would be where we would fall in that 43. So 10 different items there. Please take a look. A special shout out to Jody Hoffman, who has joined us today. Thanks for being here, Jody and Heidi. Kelsey Lindsay says, your thoughts on battling retrograde with IVF. I have no results with fertilization of embryos with it. If you mean retrograde ejaculation, retrograde ejaculation is a problem where when the man ejaculates, the sperm goes backward into the bladder instead of coming out from the genitals. So if it's in the bladder, then it can be extracted from urine. The laboratory is very proficient with being able to do that. They take a urine specimen, they prepare it, and they spin it down and can separate out the sperm there that can then be used for IVF, just like sperm would be in a normally ejaculated specimen. So should be pretty straightforward business. Hi to Shay Dunn 99. Nice to see you this day. We got about a minute left here. Let's see. Mish Marks, it looks like, hesitant on starting DHEA is recommended due to hormonal changes. Do I need to get baseline labs done first and continue to monitor labs while taking it? Well, so DHEA, if you're hesitant to, the recommended dose for lower egg or for diminished ovarian reserve is 25 milligrams 3 times a day. We can see hormone levels, DHEA levels up to 650 and say that's going to be normal. So even if you want to take it once a day because you're nervous, it should not have an adverse effect on you. So you can taper it, you can titrate it, go up as you feel comfortable. I do like to check levels on people who are consistently on DHEA, but yep, there is always an answer there. Well, it looks like we are going to run out of time here like we do every afternoon at 5 o'clock in the mountains. So 7 o'clock on the East Coast, and that means time to think about wrapping up here. It's always so nice to be with such a great group of people. I see some of the same names. I appreciate you being my friends and being with me here, as well as all the new names who join. And gosh, we really try to get to all of your questions, but I know I don't do a great job to answer everything. My colleague here at CNY Colorado, Brandis Montez, does have an open forum for questions through her Instagram, which is Brandis Courtney. And I believe that's every Thursday. So keep your eyes peeled for that. The world does not have enough kindness. Every step, like the sign says behind me there, every step forward with kindness, every step forward with love, and know that every new day brings hope. There is hope for a brighter tomorrow. This whole business is not your novel. This is merely a chapter, and we are here to help you rewrite it. So thanks again so much for being here. God bless. See you next week. Good night.